Hello, hello. I'm Katie Phillips. I'm the founder of the School of Self-Love. I'm an intuitive and transformational coach, and it is my absolute pleasure to bring you My Menopause, the interview series. And we are on day 4. It has been the most incredible journey so far. I've learned so much. I'm just loving every second, and every single expert I'm speaking to is bringing something new to the picture. But what's really encouraging is there's a common theme running throughout around this very powerful message that menopause, A, it needs to be talked about, B, it's the most natural transition a woman can go through, and C, we can actually create an experience of it that is positive. It doesn't have to be all bad. It doesn't have to be the end of the road. It's not all downhill and we're old. But it's not what it's about. We're redefining and reimagining menopause through this series, and I'm just freaking loving it. And I'm so glad to have the wonderful Dr. Wendy Denning joining us today. Hi, Wendy.
Hi.
Hello, hello. We're going to be talking all things HRT, and it's timely because, as I was saying to you before we came on the call, HRT has obviously been mentioned time and time again throughout the week. And I'm already sensing that some of the way it's been spoken about is a bit hearsay, a little bit rumor, a little bit no one's really sure. What is it anyway? So you are going to answer all of our questions today.
I'll certainly try.
I think you're well placed to. I'm going to kick off by reading your bio, if that's okay.
Yep.
Okay, so Dr. Wendy Denning is a GP with over 25 years experience. She's been named 3 years in a row in Tatler's top 150 private doctors, love that, and she co-presented the very successful TV series, The Diet Doctors Inside and Out. Wendy is passionate about and a strong advocate for the integration of traditional and complementary medicine, serving for 2 years on the GP steering group for the Prince of Wales Foundation for Integrated Health, and currently serving on the committee for an integrated approach to obstetrics and gynecology in this country. She lectures regularly to doctors and complementary practitioners on varied subjects, including the menopause. In 2007, she created her own Harley Street clinic for health doctors, which combines the best of traditional medicine with complementary medicine. And I could go on because I have about 2 pages of bio for you, Wendy. I think your accolades, they go on and on and on. Suffice to say, I am absolutely honoured that you've given us an hour of your time today, and thank you so much for being here and part of this really groundbreaking and important series.
I feel very passionate about the menopause, actually. When I was living in Vancouver, working in Vancouver, I was just hitting 30, and I didn't know much about the menopause actually. And all of a sudden, all these 50-year-old women came pouring into my office. And I very quickly had to learn that something that I'd hoped was never going to happen to me was going to happen to me, and I needed to get educated about it. And it was, and I've been interested in it ever since, really. It's been at least the last 20 years. And I felt for women who would come in and say suddenly they've gone from being vibrant in their sex lives to not caring if they ever had sex again, like the light bulb would come off with them. They might be crying, they might be very upset, and I quickly learned that I needed to educate myself and find out how I could help these women.
And do you mind? Yeah, no, that's brilliant. Can you share your journey around menopause? Are you happy to share your personal experience?
Well, my own, just finishing up on that. So just finishing up on that. My own personal experience in menopause is that I had children late, actually. And so actually I came up to the menopause with quite young children, and working. And so the combination meant that I felt that I needed to do something that was quite, I needed to go onto hormones, because I actually didn't have, I was still in a phase of being woken at night with the children and working, and a husband traveling. And personally, I needed HRT to help me through that transition.
Yeah, absolutely. Well, well, before we even get into the HRT conversation, as you said, you realized this is something you needed to help women with because you had so many coming through your doors with menopausal symptoms. I think you told me you had well, at the moment, your practice is 30 to 50% menopausal women.
True.
So what are they presenting with? What are you seeing the most common complaints, worries, concerns coming through?
I would say, I mean, they're the classic symptoms, which are hot flashes, night sweats, insomnia, lack of libido, anxiety, lack of confidence, irritability. And if I expand on that, I have women that might be working in the city. They might have been used to standing up in front of 200 people, wouldn't give it a second thought. Suddenly they're thinking, how can I possibly do that? I've got other women who have always slept well, and that's saved them through their lives to sleep well, you know, face the next day, suddenly not being able to sleep at night and desperate to get a good night's sleep and not wanting to go on pills for that. Other women, I've mentioned it before, lack of libido. All of a sudden they couldn't care less if they ever had sex again. And some women don't care, but for themselves, some care passionately for themselves. But all husbands, it seems, across the board, unless husbands have or partners have an erection problem themselves or a sexual problem themselves, they all care. And it therefore impacts on most relationships. And I think the other one is suddenly, that this is the one, you know, also is irritability. Suddenly they're screaming at the kids, and very often women have also got teenage kids at that point, so the kids are screaming back, and the combination's not a good one.
No, it's tough actually. We've got teenage daughters as well. They're kind of
it's tough.
You're going losing your period and there's hormones flying everywhere. Yeah, it's full on, isn't it?
Of course, some women are very relieved to lose their periods. They've had enough of, you know, doing all of that, and some women are very relieved to lose their periods. But I know what you mean. Yeah.
I can't wait to not have a period again.
There you go.
I can't wait to pack for holidays and not think, do I need to pack some stuff just in case? Like, I just cannot wait to not think about it again. Tell me, from your perspective as a GP, do you think menopause is handled well in the UK?
I don't think it's handled particularly well in this country, actually. I think that doctors are not educated specifically in the menopause enough. I think a lot of the education comes from the drug companies for this. I think that there are quite a lot of studies that have been done on the menopause, and I don't think some of the interpretations have been shortened to give the wrong advice to doctors, if you like. That's probably a best way of describing that. And so I think that HRT is handed out reluctantly. I think it's handed out with you can only have this for 5 years, that's the end of it. It comes with a lot of risks and warning labeled attached to it. And in the meantime, no one's really, I think, connecting with how that woman's feeling, how that woman is going to deal with the next 30 years of her life, potentially, or longer. You know, how is, you know, if someone says to you, right, well, you can have these hormones for 5 years, but sorry, after that, you're on your own and I won't be prescribing them anymore. She's thinking to herself, okay, well, what happens for the 25 years after that I'm going to live, and my bones and my, you know, and my brain and my heart, and who's going to help me with all of that at that point?
Yeah, absolutely. Do you think GPs in the UK are well trained to have conversations with women around menopause?
I don't actually. I think that GPs are, on the whole, I think the ones that end up being well trained are either women who've gone through the menopause themselves and suffered through the menopause, so doctors that have suffered themselves through the menopause and have had to find a solution, or husbands of women who've had a difficulty around the menopause and they've been able to succeed in finding a solution to that. I think the husbands that have not had the wives find a solution tend to sort of not want to deal with it because it might maybe remind them too much of their own issues at home. But yes, and I think you know, many younger women probably were a bit like me as a doctor, not really understanding the implications of it, really. When I was 30, I didn't really understand the implications of it. My mother had sailed through the menopause, and so I didn't have any experience of someone having a difficult experience with the menopause. So I didn't see it as something that I'd had. Yeah, I didn't have any experience of it. So I had to learn to find that experience. And the patients taught me, really. That's who taught me, the patients.
Yes, I bet they did, actually. That probably was a really good grounding for you, like a foundation for...
I felt for them. I just felt for them. And I thought, right, I've got to find out how I can help these people, you know.
Yeah, absolutely. No, I get that. As a coach, I get that. A lot of the women I work with, I'm working with pieces that I had to heal some time ago. Yeah. So let's dive into HRT and bioidentical hormones. Can you please define the difference between the two, HRT and bioidentical?
There is no difference in some ways. HRT just is hormone replacement therapy. That is what it stands for. And bioidentical hormone replacement therapy is still a hormone replacement therapy. So in a sense, it's a subsection of the bigger title, if you like. The title is hormone replacement therapy, and then within that is bioidentical hormones. But people like to put them in two camps, but they're not in two camps. They are in the same camp. As soon as you take any hormones in the menopause, you're on hormone replacement, full stop. But the reason why they end up in two camps is because there are such different approaches to hormone replacement therapy. And so, and this is very important because there are some things that women, I don't think, should ever be given in the menopause, and some things which I think they can take in the menopause. And this is where the conversation around bioidentical hormones, or body identical hormones, as some people like to call them now, is very important. So for instance, if we start with, I think progesterone or progestogens are the big conversation there. That's the biggest conversation. And unfortunately, that term is used interchangeably. So anyone coming to a doctor, for the most part, will be told they're going on progesterones. But actually, an awful lot of people are actually being given a synthetic version, which is a synthetic progestogen. And there is a big difference between these two, because natural progesterone carries with it a lot of benefits and has very little negatives, whereas the progestogens, we are well known, we've known for 25, 30 years, they increase your risk of breast cancer, increase your risk of heart attacks and strokes. We know that. We've known it for years. We've done endless studies on it, and every time we do these studies, we come back to the same conclusions. So that's one really, so, you know, I would say to all women going to see a doctor, if you're thinking about going on hormones in the menopause, ask for natural progesterone and make sure it comes in different forms, micronized progesterone. Make sure that you get that rather than synthetic progestogen.
Right. Okay.
That is a really important differentiation. Okay. That is probably the most important differentiation. I will not, the first conversation I have with women that turn up in my office, I say to them, if you will only get natural progesterone in this office. I will not give you anything else, actually.
Right.
Full stop. Because there's no need to. There's no need to. You have the natural progesterone. It's available on the NHS. It's been available on the NHS for 5 years at least. And it's been available in the country for a lot longer than that. So that's number one. Then we get on to the estrogen component of it. And there again, there are many different forms of estrogen that you can have. But one of the things I would say to women is make sure that you don't get prescribed estrogens for horses, i.e. equine estrogens. And I'm going to stay off brand names here because I think it's better. But there are hormones that come from horses' urine, which historically was great because that was the only form of estrogen that was available. So great. It was great when we needed it, but we don't need it anymore. And we know that those hormones are not safely broken down in the body as hormones that our bodies are used to. And so I would again say, please don't ask for equine estrogens when you go in to see the doctor. So that's another important differentiation. It is that bioidentical hormones are hormones that the body is used to metabolizing. It metabolizes for all the years of a woman's life, and those are the ones you want to be replacing. So those are two important differentiations in these groups. I think the next important part about it is that when we're thinking about bioidentical hormones, we're aware that there are other hormones that play a part at this point in the menopause. And those are hormones such as testosterone, DHEA, thyroid, and all of those things play a part in the menopause as well, because all of our hormones work together. So if the female hormones are going out of whack, so are a lot of other hormones going out of whack. Sometimes it may be temporary, sometimes it may be more permanent. Mm-hmm. And I think, you asked me earlier about whether menopause was handled well in this country. And one of the things is almost no women are given testosterone in the menopause in this country. And I've been collecting articles on menopause for years. As I told you, I've been thinking about it for years. I came across, I love this article. It's back in 1991. It was written, "Testosterone gives boost to postmenopausal women." This was an article that was in a paper in Canada, in Montreal. And then back in 1991, they were talking about the usefulness of testosterone in the menopause. In this country, it's off license to give testosterone to any woman unless she's had surgical removal of her ovaries. And yet we know, so can I give it? Yes, I can, but I have to give it on a patient by patient basis. As a result of that, GPs feel a bit nervous about it. And as a result of that, no drug company has produced testosterone in a format that's designed for women yet in this country. So the only way to get it is to get a gel that's designed for men and sort of squeeze out about a fifth of it that is your dose. Which is shocking, really, in this day and age. If you think that that's in Montreal, and that was nearly 30 years ago now.
Wow. Why are we behind?
I think... that's a much bigger conversation. Sure it is. But I suspect it's got something to do with our, I don't know, has it got something to do with our approach to sex? Has it got something to do with our approach to older women in this country? Has it got something to do with the fact that the NHS is responsible for a lot of these prescriptions, and how much do we expect the NHS to really provide for? I think it's a much bigger conversation. But one thing is very clear, that there's a very strong movement of women now in this country, which is why this is great, of women wanting a better approach to the menopause than they've had.
Yeah, absolutely.
That's crystal clear.
Okay. Why has HRT got such a bad rap?
Well, it is because of these conflicting studies, and so there was if you look at some of the studies going back, one of the studies looked at the fact that if you give estrogen alone, you have an increased risk of endometrial cancer. Now, that study was done back in the 1990s, one of the studies, and again, there's two thoughts there, but we'll finish the first thought, which is that we know that unopposed estrogen increases your risk for endometrial cancer. Okay, so there's always been a concern around that as to whether you can give estrogen alone or not. So what happens is that women who've got had a uterus removed, had a hysterectomy, will be offered only purely estrogen. Now, I will always offer the progesterone component, no matter whether they've had a uterus removed or not, because progesterone, natural progesterone, has a role itself in offsetting the estrogen effects of on the breast, It has a neuroprotective effect on the brain. So people feel less anxious on natural progesterone. They feel less depressed on it for the most part. And it also helps with insomnia, and it helps with a number of these other things. So, but if we think back to those original studies, we find that so there was the risk of increased endometrial cancer. And so everyone said, right, well, we must give everyone progesterone. And that what they gave them was progestogens. They didn't give them natural progesterone because it wasn't available at that time. Why wasn't it available at that time? Because drug companies cannot label or cannot get a patent for normal hormones. They can only get a patent if they produce hormones in a different way. So synthetic hormones had to be created, and that rather than just having progesterone given in a pill form. Now, the reason it's changed is because it's now put in what we call a micronized form of progesterone. And so you can patent a delivery system, but you can't patent a hormone. Does that make sense? So a lot of women were then given progestogens for the next 25 years. And what we know, as what I've said right up front, is progestogens increase your risk of heart attacks, breast cancer, and strokes. So then a whole load of studies came out saying how unsafe HRT was, because we are looking at a population that were getting equine estrogen, which I talked about much earlier, and getting progestogens. No great surprise in my mind that these things had adverse effects on a woman's body. You're giving them hormones the woman's not used to, the body's not used to breaking down. No great surprise. If you give that over a long period of time, you're going to have adverse effects. So what's great though is over the last since the century changed, since 2000, year 2000, there have been some other studies that have come out showing that if you give a different form of estrogen and you give natural progesterone, you considerably lower those risks, and you actually bring those risks right down to almost the level where there's no risk at all. So a lot of this, so that's why it's got a bad rap. But I still continue to see women in my office who have been given the old hormones, and until GPs are educated not to give those old hormones, those ongoing risks will continue, and patients will have more adverse side effects actually, and so we'll continue with, if you like, a bad rap.
Gosh, this is a really important conversation to be having then. If I can't quite get my head around the fact that GPs are still, why are they still dishing out the old stuff? Why aren't they up to date, and why do you know differently and they don't? Why is this still
I mean, I've made it my business to find out. I have, that's one thing. I think the British Menopause Society are trying their best to educate. They set up seminars and they have a yearly conference and they go around the country giving education. But you have to imagine that that only touches a small percentage of people. If you like, the menopause is still considered sort of it isn't a disease. It's not a disease, actually. It shouldn't be considered one. And if you like, doctors are trained in disease. So the question is, are they the best people to be really advising women about the menopause? And yes, they are, because hormones are drugs, if you like, but then they need the training to do that.
Yeah, absolutely. Absolutely.
And I think it is a pity, because one of the things we do know, if we look at these sort of more longitudinal studies, and unfortunately longitudinal studies are criticized because they're not randomly controlled, And so they're criticized for that reason. But if we look at some of the more longitudinal studies, like the nurses study and a study in France, we see that women have an increased or we see that they have a much better outcome for cardiovascular disease if in fact they're on hormones. And that's one of the things that we've known for many years. But then there was another study that put it in jeopardy, and that kind of got everyone's attention for a while. But again, it comes back to the same thing, that if it depends on what you give to people. And we come back to the same thing, which is that if you give estrogens in a safe form, which we haven't touched on, maybe we can touch on in a minute, and we give natural progesterone, we actually can improve women's cardiovascular risk. And I think that's very important. Also, we also help them with osteoporosis. But you have to start the hormones right at the time of the menopause to effect a change for the bone density, because women lose a considerable amount of bone mass right at the time of the menopause. So you have to go right in with that. And the same thing actually for the cardiovascular risk. If you want to make a difference to their cardiovascular risk, you have to do it within that first 10 years of the menopause. So that is the time when you need to be giving women hormones. And I think it's a pity. There may be more interest in this country now in that we've now seen that actually giving the biphosphonates have quite a negative effect on women if they take them for 30 years, and they may actually make the bones more brittle. And so I think we will see a swing back to HRT as a way of protecting women's bones.
Interesting. What is it that you wanted to say about estrogen in a safe form?
Good, thank you. If you take oral estrogens, which are still given quite readily in this country, you will increase your risk of clots, and you'll increase your cholesterol, because it all has to go processed through the liver. And given that we have other forms of delivery, there's no need for us to be having it all going orally in that way. And so I would advise all women to ask their doctors for either estrogel or a transdermal patch, which come in different forms, or estradiol gel, I guess, because there are different forms of gel that are available. And that is important because the majority, so if we look at that of the French study, for instance, that I mentioned, I think 85% of women in that French study were taking a transdermal form of estrogen. So that tells you what's going on in other countries.
Interesting. I'm just noticing some Q&As are coming in.
Okay.
I won't jump into them just yet, but just to say, if you do have any questions for Wendy, you can write them in the Q&A box, which is at the bottom of your screen, if you're watching this through Zoom. If you're on Facebook, Wendy, are you on Facebook?
I am, but not currently. I mean,
I'm wondering if people do leave questions under the Facebook feeds, would you better go in there at another time and answer them?
It will be another time, but yes.
Yeah, okay, great. So we won't be doing that live now. Before we move on to some of the questions I wanted to ask you, when we were speaking about this idea that not all GPs are clued up to date with menopause, where else can we go if not the GP? Where else what would our other options be to get advice around?
Question. I mean, I think that is a good question. I think women get a lot of their information from reading articles, reading books, and from speaking to their friends, to be honest. And I think the movement in this country to make GPs more aware of the changes is coming from women, and I honor women for that, because that is often why the medical profession changes, because there's enough public input on the medical profession for them to say, okay, we've got such demand, we're going to have to change here. So I do really honour that. That's one of the reasons I wanted to be involved in this, is because actually you can educate from the inside out, but actually the pressure comes from the outside.
Right.
And there are, I mean, thankfully there are a whole host of books that are available, some really, good books that are available to read about the changes that women find in their menopause.
Another, I heard, and I really don't know, but I heard something about the NHS got some menopause centres or clinics.
They do, yes. And I think the only thing I will say about the NHS menopause clinics is that almost all of them will not give you body identical hormones. Having said, well, let me rephrase that. It's actually not true. They do give you body identical hormones, but they won't call them giving body identical hormones. So you might think, oh, well, I'm not getting body identical hormones, but actually you will do, providing you ask for them.
Right. Okay. So now that's perfect. So that leads me into what I want to talk about now, because I think we need help in how to communicate with our GPs or whoever we're going to for HRT or bioidentical hormones. So how does a woman get the information she wants? Like, what are the best questions she needs to, like, if you could give her a checklist of questions to go to her doctor with, what would they be?
Okay. So they've got 10 minutes when they go to see the doctor. Okay, so they've got to kind of cut to the chase. I would like to know what training the doctor has, but that might not be the best way to get your doctor's attention. So it might just antagonize the doctor. You may end up with nothing. But exactly. So I think the important questions are what regime are you going to be giving me? If that might not come at the beginning of the question, but these are the questions that need to be addressed. If I'm going to take HRT, what regime are you going to be giving me? And will that contain natural progesterone? So that's number one. Or if you like to, we can cut near as the chase and can I have natural progesterone? But doctors don't usually like to have things demanded from them. They prefer to be asked questions.
If the doctor says, why do you want natural progesterone? What does she answer?
Her answer is, because I have read about natural progesterone and I understand that it improves the quality of my sleep, will protect my uterus, won't have a negative impact on my heart, and will lower my risks for breast cancer.
Beautiful. Okay, carry on. What else do we need to be asking?
Okay, then I would ask for, can I have a transdermal? That means something that's applied to the skin, form of estrogen given to me. Why would I want to do that? I want to do that because it will decrease my risks of a stroke and a DVT. It does put less strain on my liver, and it's in general a safer option. There is a small percentage of patients that don't do that well on a transdermal approach to the menopause, but that's a small percentage, and you only find out whether you're one of those patients by trying it.
Right. Okay. I'm like getting goosebumps hearing you speak like this. This is so powerful for women to know how. I know for me, I don't feel actually that. Maybe I need to save this question, but let's just log this question, because like, how do we even know when we're ready to ask for HRT? Because
we can come back to that.
Yeah, I'm in perimenopause now, and I don't feel like I need to go to talk to anyone yet to go on any kind of HRT yet. I just know I'm in early stages and I can see shifts happening. But I wonder when. Anyway, we'll come back to that. So what else? Well, actually, no, when do we ask the doctor? When do we go in and say, hey?
Okay. Yeah, and I suppose, all right, let's finish the questions, only because I just thought of, will this regime reduce my risk of getting osteoporosis? Will I gain weight? Those are, on this regime. And if so, how can I help myself in that regard. That's an important question because many women want to know, are they going to gain weight? Will this regime keep my risk of breast cancer down? We've touched on that. How are you going to monitor me on the HRT? And what should I do if I have side effects? Those are the questions.
Oh, I literally am getting chills. I feel so many people need to hear that, to feel empowered. We need to feel empowered when we go to our doctor. I need to feel empowered when I go to my doctor about anything. I feel like I haven't got a clue what's going on in my body. I'm handing over control to some other person who I'm praying has the information I need. And I never feel particularly confident in having conversations with my GPs. And that's no reflection on my GP. In fact, my GP is wonderful, but I never feel confident myself. And I think for something like this, that we are going to go through, every woman is going to go through, she needs to feel empowered to be able to get the help that she needs, to know what questions to ask. This is just so important. Yeah. So when do I go to my GP and ask?
Well, I will tell you who comes to see me. There are first of all, the perimenopause, can start up to 10 years before the actual menopause. And that actually, and the defined age, or the age that most people recognize the menopause as starting, is age 51. So if you imagine 10 years before that, we're starting in our 40s to get menopausal symptoms. Some women are. What are those menopausal symptoms? That perimenopausal symptoms at that point, they can be everything from hot sweats, very frequently night sweats with periods is a common one, for instance. Now, as you move more into the menopause, you might get night sweats every night, but in the perimenopause, you might just get them with your periods. You might also just get them when you've had a heavy drinking night, for instance. Lack of libido. Suddenly women notice that their libido is just dropping a bit and they can't figure it out. They're very happy with their partner, nothing's changed, and suddenly they're kind of, oh, actually, I'd rather have a good sleep. So that might be another one that shows up early, is vaginal dryness, and we haven't touched on that yet, but that can be something that can be quite problematic for women, because if it hurts when you're having sex, you're not going to do it. It's a basic. So it's got to be enjoyable, and that's an easy one to solve. So, but it's also one that many women haven't historically wanted to talk about.
When you say it's easy to solve, how, why?
Well, there are two preparations that are available. I prefer, there's a new one, which is, when I say new, it's been available for probably the last 10 years, which is estradiol, and there's one that's been around for 30 years, which is estriol cream. I prefer the estriol cream, and the reason I prefer it is the estriol is a much weaker estrogen, and it's a much safer estrogen. And if you're just using it in the vaginal region, we know that actually estriol, one of its prime functions is to plump up the tissues in the vagina. So 80 to 90% of people will get benefit from just using the estriol cream. And why increase your risk of taking another estrogen if you don't need to? And that's particularly important in the perimenopause, because in the perimenopause, women may be what we call estrogen dominant, funnily enough. They may have enough estrogen, or the estrogen to progesterone ratio may be out of balance, and so taking a weaker estrogen just for that particular symptom may work better,
right,
and be safer.
Okay.
Sometimes a lot of information, but you can play it back.
I'm totally playing it back and writing notes at the end of this. This is so going back to the question, when do I start asking my GP for HRT, at what point?
I think that's a good question. The NHS, or NICE guidelines, have now determined that GPs should not be doing any blood tests on women. So it's been decided that you can give HRT when women show up with the symptoms of the menopause. I don't know if that's a good or a bad thing, because I think instinctively women like to know what's going on in the body, which is what we were talking about earlier. And instinctively, all the women that walk into my office say, I would like to have a blood test to see where I am on you know, and the only way I can really tell them is we can talk about how long ago their last period was, but actually blood tests are quite useful. Anyway, certainly if you've started to skip periods, that's an important one, because obviously you are edging up towards the menopause. And if you are starting to get the symptoms of the menopause, so those are the things that we mentioned in the beginning, which are the hot flashes, the night sweats, the insomnia, the lack of libido, anxiety, irritability, lack of confidence. If you're getting those symptoms and you're missing your periods, then that would be a time where we would consider giving you hormones. As I say, I would often give women some hormones in the perimenopause, and the two hormones I'd be looking at that time would be testosterone and progesterone. As women go into the perimenopause, their levels of progesterone drop, and that's because progesterone is produced, yes, it's produced by the ovaries, but it's also produced by ovulating. So if you have a ovulation, you then produce good levels of progesterone to prepare the uterus for a pregnancy, and then they drop if the pregnancy doesn't happen. So in the perimenopause, in that period, very often as women edge up towards the menopause, they're not going to be ovulating so much. They're not going to be producing as much progesterone. And that may show itself in shortened cycles. It may sometimes show itself in heavier cycles. But it's a time where very often women get insomnia, or they very irritable before their periods, and that may be a time for them to have some natural progesterone. And funnily enough, if they are progesterone deficient during that time, then by giving them natural progesterone in the perimenopause, you may actually reduce their risk of breast cancer.
Right. See, I always kind of had it in my mind that I wouldn't go to a doctor for HRT unless I felt like I was going a bit crazy. Right? Like, so I kind of like the shit had to hit the fan, and then I'd be like, oh my God, obviously I need drugs, you know.
Well, I think that's a reasonable point of view. I don't think there's anything wrong with that point of view, because not all women want to go on hormones.
No, I don't really. I like the idea of going natural, but I'm also this is why I'm getting so much from this series. I also trust that maybe it's okay. Like, let's drop the stigma around taking hormones, because I'm such a natural girl. I do like, my health and well-being is such a high value for me. I would like to think, it's a bit like when I was pregnant, I wanted to be the natural mama that did the water birth and all that. And in the end, all those choices were taken away because of various things, various complications, and I had to have a C-section. It was like the absolute opposite of what I wanted. But in the end, that's what my body needed. That's just the way it was going to be for me. So I'm very open to maybe not going down the natural route, but I'm imagining that if I need to go down that route, I'm going to be like ripping my hair out. But I'm wondering that doesn't seem to be a very conscious way of doing it. Like, I kind of, wouldn't it be nice? Is there another way? Can I preempt that? Like, why? It's a bit like I say to clients, why wait till you're on the floor coping with life before you hire a coach? Why not take care of yourself now so you never have to hit rock bottom? So
I agree with you, and at the same time, look at what happened with your pregnancy and your delivery. You wanted one thing, and then you ended up going another way, and that often happens for a whole variety of reasons. There are some women that go, right, I'm definitely having an elective C-section, never mind the rest of it, and but actually most women do want to go the natural route, do want to see if they can try and do it naturally, and then thankfully we have a backup for if things aren't going well. So I think a lot of women do want to try and see how they're going to be in the menopause, and they don't always want to take jump on it immediately and take HRT the minute they get a hot flash or the minute they miss a period. They actually want to see, are they going to be a woman that can see their way through this passage of time without HRT or not? And some will have an opinion about it because their mum, ended up getting very depressed and, was a nightmare, and they don't ever want to be like that. Or others that watch their mum, sail into her own at the menopause and not need any HRT. So a lot of it's going to be down to what experience they've had in the family, what pressures they're under, and what their partner feels about it. Sometimes I have husbands ringing me up and say, I don't know what you're going to do, but please help me because she's gone off sex completely and I feel like she doesn't love me anymore. Please help me, So I think there are a lot of different pressures that come in at the menopause. But one of the interesting articles I read years ago, it's in the BMJ, was about HRT and work. And the article was very much saying that if women are working a very a very intense work schedule, the likelihood of them needing HRT in the menopause is quite high.
Right.
And I would agree with that.
Interesting. Okay.
Just purely to have the energy for that and to be able to compete with their male colleagues.
Really interesting. Okay.
So we have to keep an open mind.
Yeah, we do. We absolutely do. I think we have to keep an open mind and yeah. Just on when you were speaking about blood tests, what occurred to me was, do we not need a blood test to see what our hormone levels are to know what level of hormone to prescribe?
It's a very good question. I personally think yes. I don't prescribe because the problem, and I personally think that we need hormone levels to see whether we're well into the menopause or whether we're not actually. But you could argue, and one can argue in the end, and then the NICE guidelines have argued that if we're treating women for menopausal symptoms, then surely the main thing is what are those symptoms rather than what are the blood tests showing. And that's an argument. The problem with that argument is, let me use an example of that. It used to be that there was a certain doctor that I used to get all the failures from that would get on implants, okay? They were having their implants and they would go and they would come back in 6 months and they would get the next implants of hormones.
Oh, implants of hormones, right. Okay.
Yeah.
Okay.
And so they would get their implant and then they would come back in 6 months' time and have another implant in. Now, the problem was that those women were getting symptoms of the menopause, even though estrogen levels are incredibly high. And why was that? The reason was because the body had got used to high levels of hormones. And the whole thing about the menopause is that a lot of the symptoms come along as a result of hormone levels dropping. And it's that fluctuation in the hormone levels that actually produce the symptoms. So it doesn't always follow that just because you've got symptoms that your hormone levels are on the floor. They very often are. But you have to look at the whole picture. How long has it been since the last period? What age is the woman? What's happened to her recently? Some of those factors.
When we're prescribed hormones, are we not prescribed a level, a particular amount of dosage? I don't know what the terminology is. We're prescribed a dosage level amount.
We are prescribed a dosage, or I will prescribe a dosage, and I do base it personally on what people's hormone levels are. However, what you have to also understand is that what your hormone level today might be different to tomorrow, and it certainly is different. If you're still in a cycle, then your estrogen levels cycle throughout the whole cycle. So what it is at this point and what it is at that point may not correlate. They may be very different. So as women lose their periods, one of the things we do know is that women's hormones, certainly at the beginning of that time, are still cycling. So you come in a snapshot, haven't had a period for 3 months. I don't know where you are in your cycle. You don't know where you are in your cycle. You may have a very high estrogen level at that moment, that particular day, but yet you're still getting your menopausal symptoms. That's why it's confusing. Now, how do I deal with that? I don't deal with that by not taking the blood test. I deal with that by saying, oh, that's good. Your ovaries still got good reserve left. I think we will give you a low dose of hormones because clearly sometimes your hormones are quite a lot lower. And therefore, it seems like you would benefit from having a small amount of hormones to help balance you out. But I can say that you may have times where we almost feel that you've got too much hormones because you are clearly still cycling and your ovary is still producing levels of estrogen. So that's all about fine-tuning hormones at that point. But it is, I suppose, that's the difficulty around it. I don't think the answer to that is not to take hormone tests, though. I think the answer to that is to interpret the hormone test appropriately. Does that make sense?
Yeah, it does. It does.
Because what the NICE guidelines have said, we're just not going to take any blood tests. We're just not going to know. And I find that instinctively, it doesn't instinctually make sense. Just as you said, don't we need to know what our hormone levels are? Yes, we need to know, are these ovaries still producing good levels of estrogen or not?
Yeah. And it's a good point. Of course, hormonally, we're shifting all the time, every day.
Absolutely.
Yeah. Right. Next question to ask our GP. How can she get the right medication and ensure she's always on the right medication throughout her menopause?
Well, I think we come back to what I was saying originally, which is ask for a transdermal estrogen and ask for a natural progesterone. I would also say if you're lacking in confidence, got issues with bone density, and I'm not sure we've got the time to explore that, but then I would, or issues with libido, confidence, then testosterone may be a useful adjunct to that.
Okay.
And that would be, again, in a gel form.
Okay.
And I'm right now, just to clarify, there are other hormones that you can give in the menopause, but I do give them because I'm a private doctor, but I'm really focusing on what women can get from the NHS GP because I think that's going to be more useful for this talk.
Okay.
I just want to clarify that because
some Q&A coming in. Let's see what they ask because it might.
Yeah.
Okay. So what you're saying is there are other hormones that can be taken that you can prescribe because you're a private doctor that GPs can't prescribe. Okay.
And I've not gone into those because I think you can get a very good very good treatment for the menopause, if you want to call it treatment, or very good help in the menopause without needing to see a private doctor for the most part.
Okay, great. How can a woman find out whether taking HRT is something she can do long term?
Well, I think one of the things about HRT is, look, if someone's had a brush with breast cancer, I'm not going to give them HRT. Okay, it's not going to happen because we know that women who've got a breast cancer will have an increased risk of, so a hidden breast cancer will have an increased risk of getting a cancer if you give them HRT. They've had cancer and they've had it treated, and we might consider aspects of that. But that's a very specialized niche area, and I'm not going to go into it right now. So we look at things like genetics. If there's been, a strong family history of breast cancer in the family, we might think twice about it. If the woman is a very heavy drinker, I might ask her whether she wants to take another risk factor for breast cancer. On the other hand, if she's got a very strong family history, as I do in my family, of cardiovascular disease and osteoporosis, I'm going to be very keen to put that woman on HRT if she wants to go on it.
Right. Okay. Is it safe to take HRT long term?
the thing is, people ask about the HRT and then they forget about all the other risk factors that increase your risk of diseases. The majority, people always talk about breast cancer, but the most women are going to die from a cardiovascular event in this country, in fact. So if you look at the evidence that suggests that HRT actually protects your cardiovascular system, that's number one. Yes, is it safe? Yes, it can be safe, provided you take the right form of HRT. Then you also have to look at all the other factors that you are going to do to actually lower your risk of diseases in general as you age. And these include things like exercise and, and what you eat. Brassica vegetables. If you eat brassica vegetables, you can reduce your breast cancer risk by 30% if you have 4 helpings in a week.
What's a brassica vegetable?
Things like cauliflower, broccoli, cabbage. Those are the brassica vegetables. They're classic. And well, I won't go. Yeah, I was going to say that there's some people are advised not to take that. I don't think it's relevant here. But coming back to that question, is it safe to do? The evidence is if you have the right form of hormones, it probably doesn't increase your risk of breast cancer. I always, though, take the view that there may be a risk because there are not really any good studies that say, is there no risk at all? And so I always take the view that if the body was meant to have HRT in the menopause, it would be producing hormones in the menopause. So I always think that even if there's a minute risk, there's still a risk. And that, like any risk in life, you have to decide, are you going to take a risk-benefit ratio? And if you're going to take HRT over here, what are you going to do over there? Are you going to reduce your alcohol? Are you going to make sure you exercise? Are you going to make sure you've reduced things like pesticides in your life, reduced your xenoestrogen exposure? Are you going to do your bit in lowering all the other risk factors, which are, keep your weight down? Obesity is probably the biggest reason why people end up with cancers as they go forward in life. So a lot of these things are actually under your own control and are probably just as important, if not more important.
Yes, brilliant advice. And how long can a woman expect to take HRT for?
Well, I personally think, my mother-in-law is in her 80s and she's only just given up HRT. So, I think you take it for as long as your needs are there for HRT. And very often those needs in this day and age go for women right up into their 70s.
Why do I keep hearing people say you can only take it for 5 years?
Well, that's because we've got stuck on this safety of 5 years. One of the studies was stopped after 5 years because of the increased risk of strokes. And no woman wants to have a stroke. But if you look at that study, you will see that it was the form of estrogen and the form of progesterone or progestogen that was given that increased their risk of strokes.
Brilliant. This has been so valuable. I'm going to go over to the Q&A and see what questions we've got. So Jean has asked, can we top up progesterone and testosterone from food and vitamins rather than HRT?
You can boost your testosterone by exercise. And there are some supplements that are available that help you boost. They don't necessarily boost your testosterone, but they do boost your your libido. So yes, you can. The other thing I think that we haven't touched on here, which is terribly important, is the importance of sleep. And if women, one of the things that women rely on as they go into the menopause is their adrenal glands. And adrenals are helped balance the most by reducing stress and sleep. And so, yes, you can absolutely improve your whole situation by sleeping well, because the adrenals are the ones that actually produce the testosterone and produce the DHEA, which is one of the hormones that we haven't covered. And those are the hormones that actually will improve your testosterone if you improve your sleep quality. So that's number one. Do I think progesterone? No, there isn't a way of doing that. Not really, not in terms of your food. There was people thinking that if you take yams, you can increase your progesterone. No, you can't. can you take some supplements that may improve your testosterone levels? Yes, but are they enough for you in the menopause? Not certain.
Right. Okay, great. Next question from Julie. Wendy mentioned a form of estrogen together with the natural micronized progesterone as a great solution, but can she clarify which form of estrogen?
Okay, so that's the transdermal estrogen. That's either in a gel form, and there's a couple on the market, which are estradiol gels, or those are patches, and there's a number of patches. The only thing I would advise against with the patches is don't take the ones that say Conti, which means continuous, because the Conti part of those patches is the progestogen.
See, isn't this valuable, people? This is amazing. Jean, is family history of cancer taken into consideration before prescribing?
It has to be. So particularly breast cancer is taken into consideration, as is prostate cancer, as is colon cancer, by the way, and ovarian cancer and uterine cancer. But a lot of those, and particularly with breast cancer, it's often the age that's taken into consideration. So if you've got women who have family history of young breast cancer people, i.e. presenting soon into the menopause or even in their 40s, you might be very wary of giving hormones.
Yeah. Sally's asked, do you keep having periods if on HRT?
We used to, they used to, because you give quite high levels of estrogen, and then you need to make sure that you were releasing the lining of the womb in order to have a safety. I would say 97% of my patients do not have periods, and that's because I don't give high levels of estrogen. I give adequate amounts of estrogen, and then I balance it with the progesterone so they don't end up bleeding.
Mm-hmm. Okay, brilliant. And just to change the subject slightly and move it, because something we touched on before we came live, supplements.
Yeah.
Just this subject, is it safe for a woman to self-prescribe her supplements? Because I've heard that you can maybe take the wrong ones together and that can have a detrimental effect. And we should really be getting advice on what supplements to take, with what medications, with what yada yada. So what do you
I mean, I think if we look at drugs and we look at supplements, let's just have an analysis of that. The average woman in her 70s is maybe on somewhere between 5 and 7 drugs. If you're on any more than 2 drugs, it's a complete experiment in the body. Okay, so let's look at the relative risks of this and the relative risks. So taking lots of drugs is a relative risk, okay, and that's a much bigger relative risk than supplements. Most supplements, the biggest risk that you've got with them is actually the thing that they're contained in, i.e. the capsule, the gelatin in the capsule and the binders in the tablets. Those are the biggest risks. Sometimes the elements of the supplements may interfere with medication. Sometimes they may offset each other a small amount, but compared to what drugs will do, I never worry about people taking too many supplements for the most part. I think that most people naturally fall off taking supplements if they don't feel well or they're going away or something happens, they think, I'll leave them at home anyway. So they tend to take a natural break from the supplements anyway. There are very few patients of mine that take sort of 20 supplements indefinitely every day. That just, most people, it doesn't happen. So do I worry about it? Not really, because even if they knock each other out a little bit, the relative effect is not that great. Does that answer your question?
Yeah. Well, also when we were speaking before, you mentioned that sometimes there's more benefit to taking them than not taking them. Is that
yes, that's also true. So for instance, one of the things I recommend for women taking, you asked me about safety of hormones, and one of the things that I look at is how women metabolize estrogen in the body. And I do that routinely across the board because I think genetically we all metabolize our hormones slightly differently. And so if we can look and see how we metabolize our estrogen, and then we support pathways in the body that improve our metabolism of estrogen, we make an already safer cocktail even safer. And I do that by supporting certain elements of metabolism of estrogen in the body. And so a couple of supplements that one might be looking at to do that would be something like indole-3 carbinol, which helps you metabolize your estrogen safely. Another one would be something that brings your homocysteine levels down, and that would be something like a methyl complex or a homocysteine factors or something like that, which lowers your homocysteine levels. But that will also, the same things that are in that will also impact on your safe metabolism of estrogen. So I will be looking at that. If women are drinking too much alcohol, apart from asking them not to drink so much alcohol, I might be giving them some sort of liver support. So we look at different forms of supplements to augment things that we're already doing.
Do you think if a woman is self-prescribing her supplements and she wants to get an opinion, second opinion, confirmation that it's the right thing to be doing, does she go to her GP, or does she go to does she go to a nutritionist or a naturopath, or who does she go to?
I wouldn't go probably to my GP if I wanted advice on supplements. Most GPs have no training in supplements whatsoever, and then tend to be fairly suspicious of it. In fact, they tend to take the guidelines that if you just eat a normal diet, you won't need your supplements. But the reality is that actually, even patients that I have that are quite well motivated, very often they don't even make their 5 helpings of fruit and veg in a day. So, this idea of the good diet is not really accurate. And I think on top of that, if you're stressed, if you are taking more alcohol, if you're drinking coffee, if you are smoking, all of these things deplete the body of essential vitamins and minerals. And so I think women do need support as to how to support their bodies to be optimally functional. And I think the best person to go to then would be a nutritionist or a naturopath, who would then look at their diet, look at their lifestyle, and advise them on which things can best support their lifestyle, and possibly also help them modify their lifestyle slightly to a more healthy way.
I think this has been the message throughout the interview series, is the menopause is absolutely calling a woman to finally, take herself seriously and take care of herself. And I think you did talk, I know you talked about this, but can you please remind me, because I think you're right when you said sleep is such an important piece. If a woman came to you and one of her key menopausal symptoms was, I'm not getting enough sleep, what would you do to help her with that?
I think the most important thing before we get into any supplements or any drugs is looking at what we call sleep hygiene. And sleep hygiene is about how people prepare their body for sleep. And I'm still shocked in this day and age with so much information out there that people, men and women, on the computer, on the TV, on their phone, and then they brush their teeth and jump in bed, and then they wonder why they can't sleep. And you have to tell your body that it's time for sleep, and you have to be respectful to your body to say, actually, do you know what? I realize that you've been busy and my mind's been busy and I've been thinking about lots of things, and now it's time for sleep. And I want you to calm down. I want you to go to sleep, and you need to give some time to prepare for that. So, and that can take, so generally speaking, I say no phones, tablets, computers for a half an hour before people go to bed. Some people advocate much longer than that, but I'm being realistic. I live in a realistic world. And then something that they do every night. So, for instance, I personally take a hot bath every night. Once I get in the hot bath, I don't want to have, powerful discussions with my husband about, the day's events. I don't want to do that. I want to calm down for the day. I want to switch my brain off. I want to relax. I put Epsom salts in my bath. Why? Because I've increases my magnesium, increases my sulfur, helps my body detox, also helps my body relax. And that's it now. My body knows that it's time now to go to sleep, and I never have a problem getting up to sleep. If I try to do, and other women sit in a chair and listen to inspirational music, read a good book. I'm not suggesting you read a Dan Brown book, but a book that's, not too racy. And they do things that signals to their body every night that it's time for sleep. This is the most important thing. If you drink a lot of alcohol, you're going to have a broken sleep. So if you're looking for a good night's sleep, don't expect to have it after 3 glasses of wine, because it's not going to happen. And then I would be looking at how women can support their sleep. And sometimes the only way of actually achieving that is by giving something like natural progesterone. But sometimes, you can also achieve the same thing by giving magnesium at night, by giving L-theanine at night, by giving some of these other supplements that achieve that same place. But it is vital to get the sleep sorted out. The number of women that end up in the menopause with poor sleep is a tragedy, really.
Yeah, it is. It is. Wendy, this has been just so enlightening and so empowering, actually. Thank you so much. Is there any last message that you want to share with the viewers?
I think the other thing I'd like to just bring up is, which we haven't touched on, is in this day and age of the menopause and women gaining weight, is that we are all become relatively insulin resistant as we hit the menopause, i.e. we handle sugar and fast carbohydrates poorly in the menopause. As our estrogen levels lower, we don't handle those things as well, and it's one of the reasons. And so what I would say to women is, take that seriously, because you will start, if you keep continuing to eat a lot of fast carbohydrates, fast sugars, alcohol, as you hit the menopause, you will not only gain the weight, but you will get yourselves into a situation where you're developing things like the metabolic syndrome, increasing your risk for cardiovascular events, blood pressure, diabetes. So really it is the time in that way to caretake themselves. And we haven't touched on that, but that happens to all women, whether they take HRT or they don't take HRT, is that relative insulin, resistant, relatively speaking. And you can offset it in some ways, but the main thing is actually to look at your lifestyle at that time.
Absolutely. And we had, all the days are becoming a blur. I'm pretty sure it was yesterday morning we had a panel interview of nutritionists and sharing, which will support them with exactly what you just said then. Yeah, wonderful. Thank you.
Good.
Thank you for your time today. I adore you. I adore what you're doing. I love your passion for this subject, and clearly you need to be speaking out even more about this, but let's share this interview far and wide, because I think it's going to support so many women.
Thank you for inviting me. I've enjoyed the morning with you.
Brilliant. It's brilliant. I want to do it again. Thank you. And thank you everybody for joining us, and we have one more interview this afternoon, and I'll see you then. Lots of love. Bye.